as much discussion with you as possible. So please, in the discussion, try to take part. If you have any questions, we'll be happy to discuss it with you. So, first on the pathogenesis and diagnosis of CSC. First of all, I think it's important to mention that CSC is, of course, not the usual suspect in our daily medical retina practice, but still is supposed to be the fourth most common wet maculopathy after neovascular AMD, diabetic macular edema, and retinal venous occlusions. So it's not that rare. Its exact pathogenesis is unknown. And when you do fundoscopy, it can be quite difficult to see them. And let's see, there's this kind of laser thing that should work. Well, it doesn't match very well. Oh yeah, here. Well, in my experience, it can be quite difficult to see where the fluid is on fundoscopy. So OCT is, of course, very helpful. Also because OCT can show you signs of chronicity. For instance, if there is a lot of accumulation under the retina, it could be a sign of chronicity, and also the extent of RPE changes, as well as the aspect of the choroid. And I'm going to dive deeper into that later on. As you probably know, of course, on FFA, you can see the signs of focal or more diffuse leakage, but it is also clear, especially when you do a good ICG angiography, that the choroidal abnormalities are much more extensive in general than the FFA abnormalities. So you're looking at the tip of the iceberg on FFA because there are more choroidal abnormalities on ICGA. And that's why ICGA is quite important if you have it, also to guide the treatment. So there can be focal leaks, acute CSC, you don't do an FFA, you just wait for some months, and the likelihood of it resolving is 90% or more, although there is a risk of recurrence of about between 15 and 25%. But you also have these chronic cases with multifocal leakage, with extensive ICGA abnormalities of the choroid. Oops. So this can be quite impressive, and of course these cases you would really like to consider to treat. So CSC is a disease spectrum going from very focal, acute cases in often young men or pregnant women to focal chronic cases, but also severe chronic cases with more extensive atrophy, more extensive intraretinal fluid can be present actually, which is not always, often not actually related to neovascularization, but in the end, or also quite early, it can be complicated by often a type 1 neovascularization with or without a polypoidal or aneurysmal type 1 component. Here would be a typical case of acute CSC where there can be a very tiny focal leak with this smokestack leakage, which is not always present. And in many cases, this resolves spontaneously. But when it comes to chronic CSC or complex CSC, the classification is being refined more and more. There can be quite some different presentations, and it can sometimes be quite difficult to differentiate with other diseases, and we're going to cover that in the next topic, in the next talk. So spontaneous resolution in chronic CSC is also relatively common. In the Vichy trial, which was the prospective randomized controlled trial from the UK that compared eplerenone to placebo treatment, up to 30% of the placebo-treated patients after 12 months with chronic CSC had a complete resolution of subretinal fluid, and an additional, I think, 24% had partial resolution of fluid. So this also gives a caveat when looking at retrospective studies, which are very problematic in CSC. And we, not too long ago, described a sign which needs more proof, by the way, to really show that it is really an important sign. But if you have an OCT and it looks like Mount Fuji in Japan, as you see here, so it's not like dome-shaped, but more tent-shaped, they have a higher likelihood of getting a resolution, because it seems that the fluid is resolving. And this was much higher, this percentage of resolution in the people with the Fuji sign, than in the controls. And these patients also have less focal leakage, so it's maybe less active when this sign is present, but they formerly had a dome-shaped fluid accumulation. Then the term pachychoroid, of course, it's used a lot, and it means a thick choroid, but there's much more to that, and I'm going to dive more into that in the beginning of my talk on therapy. But these are the main categories that have been described. There's also the peripapillary pachychoroid, by the way, which is a variant of pachychoroid in the macula, and there's some overlap. But you can have a thickened choroid with enlarged vessels due to venous overload. But you can also have CSC, which is the hallmark disease, of course, or pachychoroid neovasculopathy. But also, and that's quite interesting, in this patient, which seems to have a normal OCT, you can actually see on FFA that there are some RPE changes. And when you then do ICGA, you can see that these typical mid-phase ICGA indistinct areas of leakage are present. So there is this pachychoroid, diseased choroid, where there are areas of leakage on ICGA, and then the RP is probably also affected secondarily, but without the leak, without the fluid. So it's, let's say, a form thrust of CSC. Now the other risk factors, of course, males are affected much more often than women. So that's actually one of the really important risk factors. So there must be a hormonal factor, I guess. It's not at all known actually why this is the case, but hormones, steroids, they have all a bit of the same structure molecularly. And of course, with age, the likelihood becomes higher, but it's often, of course, men between, let's say, 20 and 45 that present with typical CSC. We also know that genetic risk factors can play a role, but how they exactly work is not completely clear. And interestingly, it has been found that the complement factor H gene, that you probably all know as the major risk factor, genetically speaking, in AMD, has also been found to be associated with CSC. But very broadly speaking, risk factors in AMD are protective in CSC and vice versa. So in a way, I mean, patients with CSC also have a thickened choroid, whereas the AMD patients, if they don't have a CSC background, of course, they have a thinned choroid. So they seem to be relatively opposite diseases in a way. And quite interestingly, we recently just published a paper with American and Finnish group where we found an association with a gene that is not only a risk factor in CSC, but also in venous insufficiency in the legs, so varices, which is quite interesting because you have these dilated choroidal vessels in the eye too, and actually also with glaucoma, so we have no idea how that works, but let's see. Then stress. I think stress is quite intriguing in CSC because there are quite some colleagues actually who recommend patients to reduce stress as much as possible, maybe even change the way they fill in their jobs, etc., etc. I'm quite skeptical about that because the link with stress is quite controversial actually, which is not the case with steroids. If they can stop steroids, recommend them to stop steroids if it's medically defendable. So we know that steroids can really hugely increase the risk of CSC, and even in some patients, focal steroid use can be, local steroid use can be a risk factor. And up to half of the patients with CSC, they use exogenous steroids. But endogenous increased steroids, so hypercortisolism in Cushing syndrome, is also a risk factor. And when you have to suspect Cushing syndrome, you have to think about abdominal fat distribution, buffalo hump, which is in extreme circumstances, onset of diabetes, osteoporosis, etc. There are many parts of the body that can be affected. And it is tricky because we have published a series of patients who actually had oligosymptomatic Cushing syndrome who actually presented with CSC. And if you took a close look and had a high index of suspicion, it turned out they actually had Cushing syndrome. And if you ask the patients for photos over the year, you can have signs of, okay, this might be Cushing, and send them to an endocrinologist. That also made us think about, could a higher cortisol actually be present in CSC patients? And then, of course, there's also the suspicion that people with CSC can have specific personality traits. Type A personality might have different stress coping. So we thought, okay, what is this exactly? It has been also described by Professor Iannuzzi in the late 80s, the type A behavior, which is kind of a difficult definition because it's not really strongly defined. And that's why we actually looked in quite a large cohort of 88 patients with chronic CSC and 24 controls with the best endocrinologists we have in the country. We really turned the patients upside down in terms of not only testing for hypercortisolism, but also looking at personality traits. So we did a lot of testing on cortisol in urine, in hair even, in saliva. And we wanted to see if they have different cortisol metabolism. And in none of those patients actually found evidence of subclinical Cushing syndrome. So you don't have to think about that if the patient doesn't have any complaints of Cushing syndrome. So there's no need for systematic screening in CSC patients. We did find a slightly increased hyperactivity of the HPA axis, which was borderline significant. But other than that, we didn't find any signs in the chronic CSC patients of a big cortisol problem. Urine cortisol was normal, etc. And also we found that type A personality, or stressed personality, or was not any different in the chronic CSC patients, so no abnormal stress coping. So there might be a connection with stress or with cortisol, but how that exactly works and is not known. And I'm not sure if you have to give them any harsh measures in terms of reduction of stress. So we know that CSC is associated with genetic risk factors, although they're not very strong and we don't know how they exactly work. And also there is some evidence of hypercortisolism, but this is very mild, so we don't exactly know what to do with that. CSC is a multifactorial disease. There may be hormonal factors. Men are affected much more often than women, so there must be a hormonal factor. Cortisol is important, genetic factors and anatomical predisposition, and I'm going to talk more about that in my talk at the end. Thank you very much.